Hello, and welcome to the NIH Research Funding Opportunities and first look at new DM data from the CDC and the Marigold Foundation. I'm Dr. Nadine Skinner, the MDF Research Coordinator. This session is part of the DM Professional Track. It is intended for clinicians, researchers, and industry experts. This session will be available for viewing after the conference at the MDF Digital Academy at www.myotonic.org/digital-academy. I'm delighted to introduce our presenters. Sarah Howe has worked in myotonic dystrophy for 15 years as the program manager for the Marigold Foundation. Marigold is a private Canadian foundation focused on therapeutic development, research, and strategic initiatives in myotonic dystrophy. Previously, Sarah was the project coordinator for the Christopher Project, a large survey of patients, families, and caregivers living with DM1 and DM2, aimed at understanding their unmet needs and elevating the patient voice in myotonic dystrophy. She holds an MBA from the Haskins School of Business. Ms. Howe will discuss the recent project and insurance claims data analysis for myotonic dystrophy, which may help shed light on the economic burden of DM. Following Sarah, we'll hear from Dr. Glen Nuckolls, the Program Director in the Neurogenetics Cluster Division of Neuroscience in the National Institutes of Neurological Disorders and Stroke at the National Institutes of Health. Dr. Nuckolls is the department point of contact regarding research on the causes and treatments of the muscular dystrophies, spinal muscular atrophy, and inherited and acquired peripheral neuropathies. He is the Executive Secretary of the Interagency Muscular Dystrophy Coordinating Committee, the Programmatic Lead for the Senator Paul D. Wellstone Muscular Dystrophy Research Centers, and serves on the Programmatic Panel for the Duchenne Muscular Dystrophy Program of the Congressionally Directed Medical Research Programs at the Department of Defense. He also serves as the point of contact for the NINDS Rare Disease Clinical Trial Readiness Program, and participates in the trans NIH activities, including the Rare Disease Clinical Research Network. Prior to joining NINDS, Dr. Nuckolls was the Program Director for Muscle Disorders and Therapies at the National Institute for Arthritis and Musculoskeletal and Skin Disease, NIAMS, a review officer at NIAMS, and he conducted research on cartilage biology, skeletal development, and osteoarthritis in the intramural programs of NIAMS. Dr. Nuckolls completed his postdoctoral training in biochemistry at Stanford University and graduate training in cell biology and anatomy at the University of North Carolina, Chapel Hill. He will share about NINDS, NIAMS, and NHLBI funding opportunities relevant to myotonic dystrophy research, with a focus on the NINDS biomarkers and preclinical translation programs, and discuss the DM research topics currently supported by the NIH. Dr. Emily Carifi also joins this esteemed panel. Dr. Carifi is a program director for the Muscle Disorders and Therapies program at the National Institute of Arthritis and Musculoskeletal Disorders. She earned her PhD in neuroscience from Thomas Jefferson University with Dr. Davide Triati. She then completed her training with Dr. Kenneth Fishbeck at the National Institute of Neurological Disorders and Stroke. Her research background is in neuromuscular disorders, including amyotrophic lateral sclerosis, ALS, and spinal muscular atrophy. Dr. Carifi will provide an overview of NIAMS and discuss NIH funding opportunities for new investigators and trainees. Last, and certainly not least, Ms. Natalie Street is a health scientist with the Rare Disorders and Health Outcomes teams at the Centers for Disease Control and Prevention, the CDC. Currently, she manages CDC-funded muscular dystrophy activities, including Muscular Dystrophy Surveillance Tracking and Research Network, MD STARNET, a 7-site surveillance system that identifies and tracks the health of people with muscular dystrophies, including myotonic dystrophy. Ms. Street will present an overview of MD STARNet, sociodemographic and clinical descriptions of the myotonic dystrophy population in 4 U.S. states, and plans to share with us the direction of current and future MD STARNet research. Enjoy the presentation.
Hi everyone, my name is Sarah Howe. I'm the Program Manager at the Marigold Foundation in Calgary, Canada. Thank you for joining me today, and thank you to the MDF for having me. I'm pleased to speak to you today about a recent study we conducted that examines the experience of myotonic dystrophy using U.S. medical insurance claims data. The purpose of this study was to examine large U.S.-based insurance claims databases that contain health economic and clinical encounter data to better understand healthcare costs and medical resource utilization for people living with DM. Study findings will help to inform the payer case and lay important groundwork for therapeutic registration. They also provide additional insight into the DM experience for patient advocacy and clinical care providers that could improve health outcomes for patients and families. Marigold partnered with IQVIA, a world leader in health outcomes research, to conduct a retrospective, observational, real-world study of myotonic dystrophy using their new data warehouse. This enormous database includes de-identified insurance claims billing data from all healthcare channels in the US, including hospitals, providers, and pharmacies. The data source includes medical claims, pharmacy claims, hospital charge master records, behavioral and demographic information, and laboratory data. It is important to note that these type of data represent a billing code in an insurance claims database. It is not clinically reported, nor natural history data, nor chart data. As such, it has limitations in and of itself and needs to be interpreted accordingly. That said, examination of this type of data across such a large data set provides an opportunity to look at myotonic dystrophy from a unique vantage point that can complement traditional clinical perspectives and add to the growing understanding for this rare disease. For the purposes of this study, we selected a 9-year study period from 2011 to 2020 using ICD-9 and ICD-10 codes to identify myotonic dystrophy patients. Now I'll walk you through the study cohort selection process. IQVIA's new data warehouse contained over 194 million claimants in 2019, of which 35,000 had at least one diagnostic code for myotonic dystrophy. Consistent with studies of this nature, and to ensure greater certainty around diagnosis, patients were required to have at least 2 medical claims of myotonic dystrophy in order to be included in the study, resulting in over 18,000 eligible participants. At this point, it is important to note that the ICD-9 and ICD-10 codes for myotonic dystrophy do not distinguish between DM1 and DM2, nor do they distinguish the congenital form. As such, it is not possible to examine the unique patient journey of these disease subtypes. Instead, the study findings provide blended results for both DM1 and DM2. In order to illuminate the experience of those claimants who had a very early onset of myotonic dystrophy and who likely have the congenital form of the disease, the overall group was divided into 2 cohorts based on age. Those 2 years old and older at their first diagnostic code for DM were left in the DM cohort, while those under 2 years of age were separated into the congenital cohort for study purposes. These disease cohorts were matched 1-to-1 with non-disease controls on age, gender, payer type, geographic region, and index year. All unsuccessfully matched patients were excluded from the study. Finally, additional data quality criteria were applied, including continuous patient eligibility and pharmacy stability, in order to ensure we had a view to the entire claims history of the study participants. The final study cohorts included 8,541 in the DM cohort and 242 in the CDM cohort. The study examined a wealth of data, both in sample size and number of different variables we looked at. Demographics included age, gender, geographic location, and payer type. We also identified numerous variables that we labeled patient journey in order to better understand what DM patients experience throughout their care. These include diagnosing and managing physicians, comorbidities, clinical procedures, prescription drugs, pregnancy and related factors, assistive devices, and OT-PT usage. The health economic measures included all-cause healthcare resource utilization using pharmacy, outpatient, and inpatient codes, and all-cause healthcare costs. The study followed the claims history of the cohorts over 4 12-month follow-up periods. A rigorous process of descriptive analysis was used to examine all study variables to compare DM patients and CDM patients to their matched controls. Now let's move on to some of the study results. The study encompassed a broad range of claimants. The average age of the DM cohort was 46 years, and the average age of the congenital cohort was less than 1 year old. And this really is indicative of the criteria that they needed to be under 2 years old to be included in that cohort. Most of the study participants had third-party insurance coverage, but you can see the study did include the experience of a significant number of Medicaid and Medicare claimants. Now on to some of the deeper findings. Given the complex clinical presentation of myotonic dystrophy, we pulled data on all existing comorbidities, not limiting the study to a pre-selected list of possibilities. We found that both the DM and CDM cohorts presented with an elevated comorbidity profile compared to their control groups across all 4 study follow-up periods. This was most significant in the congenital group. Rich comorbidity data emerged in all major symptom areas normally impacted in myotonic dystrophy. And although there was attrition of study participants over each of the follow-up periods, the data show a clear progression of disease and an increasing comorbidity profile over the length of the study. Comorbidity data revealed an extensive number of issues that DM patients encounter in medical care, providing considerable insight into the multisystemic nature of the disease. This list here represents those that affect more than 5% of the DM cohort, with an incidence at least twice as great as the control group, with a significant p-value. You can see several major symptom areas are represented here, including cardiac, GI, and respiratory. Comorbidity for the congenital cohort was even more striking. Again, we see that these youngest study participants are impacted across many body systems and are affected significantly more than their matched controls. The complexity and severity of this neonatal form of myotonic dystrophy is clearly evident in the study results. Another major aim of this study was to examine healthcare resource utilization, commonly known as HCRU, which helps to provide important context to claims costs. An examination of HCRU for the DM cohort in the first 12-month follow-up period shows a consistent pattern of higher usage rates when compared with controls across all metrics of use. This includes average number of prescription fills, average outpatient visits, average physician office visits, ER visits, and hospitalizations. A similar examination of the congenital cohort shows even higher usage when compared with controls, as exemplified in higher usage rates in the average number of prescription fills, outpatient visits, and physician office visits. To highlight one piece of data, the average number of outpatient visits for the congenital group is 70 per year, compared to just over 8 for the control cohort. We also see a higher percentage of the CDM cohort with an ER visit and more of the CDM cohort with at least one hospitalization when compared to controls. Those CDM patients who have been hospitalized also have a much higher average length of stay and more total hospitalization days However, we do lose significance in these categories due to the small size of the specific subset of patients here. The pattern of increased HCRU for both DM and CDM continues across all subsequent study follow-up periods. Finally, the study looked at total all-cause costs, which summarize all claims-related costs for patients across their medical encounters. These include pharmacy, outpatient, physician office visits, ER costs, and inpatient costs. As highlighted, the average total all-cause costs for the DM cohort for the first 12-month follow-up period is over $16,000, significantly higher than the control. This holds across all contributing cost factors and across all 4 follow-up periods, as I'll show you shortly. Interestingly, median total all-cause costs are lower than the mean, and the standard deviation is quite high for the DM cohort. This is evidence that there is a subset of study participants who have very high costs. The CDM cohort had markedly higher average total all-cause costs compared to controls across all cost categories, including pharmacy, outpatient, and physician office visits. While the ER costs and hospitalizations are dramatically higher than controls, here too we lose statistical significance in these variables due to the small size of this specific subset of patients. Nonetheless, it is apparent that a hospitalized CDM patient costs much more than a hospitalized patient without congenital myotonic dystrophy. As with the elevated comorbidity profile described earlier, the very high costs of the congenital cohort are illustrative of the complexity of the disease and the significant needs of patients with this most severe form of myotonic dystrophy. Again, we see skewness in the distribution of the cost data as well, which is evidence that there are a subset of study participants in this cohort who have very high healthcare resource utilization. This helps illustrate the nature of congenital myotonic dystrophy and the acute needs in high-cost symptom areas. Now, let's take a moment to look at how average all-cause costs change over the patient's claims history in the database. This graph illustrates the total all-cause costs of the DM cohort compared to the controls over the 4 study periods. As you can see, total all-cause insurance claims costs for the DM cohort were substantially higher than both the study control cohort and the US national average. Additionally, the trajectory of costs for the DM cohort increases over time, which is consistent with a progressive neuromuscular disease. Costs for the control cohort approach the US national average over time, as would be expected. The total all-cause cost findings for the congenital cohort are even more dramatic. Total average all-cause medical claims costs were more than $60,000 higher than controls in the first 12-month follow-up period for this group, and significantly higher than controls across all remaining follow-up periods. The extremely high initial costs, followed by a stabilization over subsequent periods, may reflect a pattern of early acute clinical needs of neonates with congenital myotonic dystrophy. So to conclude, the tremendous amount of data examined in this study found an elevated comorbidity profile for myotonic dystrophy and congenital myotonic dystrophy cohorts that clearly demonstrates the complex and highly variable nature of myotonic dystrophy. The study also found that healthcare resource utilization per patient per year was considerably higher for both myotonic dystrophy and congenital myotonic dystrophy cohorts compared to controls across all usage areas. Further, DM and CDM cohorts have higher annual all-cause healthcare costs when compared to controls overall and across all cost categories. These findings help to demonstrate the burden of myotonic dystrophy on patients and families, the healthcare system, and payers. I'd like to thank A big thank you to the MDF and Tanya Stevenson, along with the other individuals who have been involved with the project. Study findings will be published in 2021, and the data tables from the study are available to interested parties. Please email me if you have any questions or would like to access the data tables. I look forward to hearing from you. Thanks again.
Hi, I'm Glen Nuckolls. I'm a program director in the Division of Neuroscience at the National Institute of Neurological Disorders and Stroke. And along with my colleague, Emily Carifi from NIAMS, we'll be describing funding opportunities that are relevant to myotonic dystrophy research. NIH has 27 different institutes and centers, and 3 of the institutes are the main supporters of myotonic dystrophy research. This is NINDS, NIAMS, and NHLBI. The topic is mostly shared by NINDS and NIAMS, and most studies could go to either of the institutes. If there's specifically a focus on the nervous system, it would come to NINDS. If it's on muscle stem cells, it would go to NIAMS. And if the study involves cardiac, respiratory, or sleep studies, it would go to NHLBI. All 3 of the institutes use the parent RL1 mechanism, and we also have institute-specific funding opportunities for things like biomarker and outcome measure studies, preclinical therapy development, and clinical trials. If you're interested in support for these types of specialized studies, please contact Emily or me, and we can also refer you to NHLBI as needed. This slide shows some of the topics in myotonic dystrophy research that are currently supported by NIH grants. At NIH, we really strive to support basic studies that provide foundational understanding of the diseases, as well as preclinical translation and clinical cohort characterization, in the hopes that support for these studies will lead to better understanding, key discoveries, and data sets that can be leveraged by industry to facilitate further development of therapies. So most of the studies that we support in myotonic dystrophy are supported through the RO1 or R21 grant programs that you're probably already familiar with. So for the remainder of my presentation, I'd like to describe some special funding opportunities at NINDS for preclinical translation and clinical trial readiness. NINDS has a division of translational research with a comprehensive set of funding opportunities announcements. And these kind of start with the IGNITE program, which has 3 different funding opportunities within it. It has one for developing high throughput assays and conducting high throughput screens. It has one for characterizing cell or animal models that will be used in further therapy development studies. And then it has one for supporting rigorous, well-powered proof of concept efficacy studies, usually in animal models, but if there's no animal model available, it could also be in a cell culture model system. Once you have a therapeutic lead, you can apply to the Blueprint Neurotherapeutics program for lead optimization, IND enabling studies, and even first-in-human clinical trials. We have separate tracks for small molecule drugs and biologics, which also include gene and cell therapies, oligonucleotides. These programs can provide funding for research that you do in your lab, and it also provides access to a set of consultants and contract research organizations that are supported directly by NIH. Our preclinical translational programs have special review panels for peer review, and most have separate funding opportunities for academic researchers or for small businesses. To increase the likelihood of success in clinical trials, we have a clinical trial readiness program that supports prospective, multi-site, longitudinal studies leading to clinical validations of outcome measures and biomarkers. And this program is exclusively for rare diseases within the NINDS mission. We have another set of programs just for biomarker development, and we provide grants that support biomarker discovery and other programs on analytical or clinical validation, and that's for any of the diseases within the NINDS mission area, rare or common diseases. The take-home message from my presentation is that if you need guidance on any of these specialized funding opportunity announcements for translational or clinical research, please contact Emily or me, and we'll be happy to provide guidance. Now, Emily will tell you about funding opportunities at NIAMS. She'll tell you about the Wellstone Center's program and the wide range of training, career development, and new investigator award opportunities. Thank you.
Hello, my name is Emily Carifi. I'm the Program Director for the Muscle Disorders and Therapies Program at the National Institute of Arthritis and Musculoskeletal and Skin Diseases, or NINDS. First, I want to thank the Myotonic Dystrophy Foundation for inviting me to speak with you today. First, I want to take a very brief period of time to talk about two programs here at the NIH that covers myotonic dystrophy research and that we're very excited about. So I'm sure many of you know of or are affiliated with the Wellstone Muscular Dystrophy Research Network. This is a Center of Excellence program established in 2003 and named in honor of Senator Paul D. Wellstone of Minnesota. This is part of the NIH Enhancement and Intensification of Muscular Dystrophy Research associated with the MD Care Act of 2001. These are 5-year renewable grants and are supported by 4 major NIH ICs. Mine, NIAMS, the Eunice Kennedy Shriver National Institute of Child Health and Human Development, NICHD, the National Institute of Neurological Disorders and Stroke, or NINDS, where Dr. Nuckolls is, and the National Heart, Lung, and Blood Institute. All of our institutes are very excited to be part of the Wellstone Muscular Dystrophy Network. I'm sure many of you are aware of the excellent work at the Muscular Dystrophy Wellstone Center at the University of Rochester, led by Drs. Wooten and Swanson, and with a leadership team of Dr. Twill and Dr. Berglund. This center was founded in 2003 by Dr. Moxley and has been continuously funded by NINDS. They are looking at the multi-system manifestations of DM1 and are trying to create new therapeutics. More recently, their goals have transitioned to identifying clinical endpoints and biomarkers to monitor treatment, and they have established and maintained the repository registry of myotonic dystrophy and FSHD muscular dystrophy patients and family members, which is an excellent resource for the muscular dystrophy community. The next program I'm going to discuss, our clinical observational research at NIAMS, is much smaller and unique to NIAMS. This is a small R01 with a maximum of 3 years. These are not clinical trials. The goal here are to find and identify the significant obstacles preventing the start of a clinical trial, and find an appropriate outcome measure, looking for biomarkers, and identify which stage of disease is most appropriate for therapeutic intervention. These are opportunities for those who are looking to transition into the clinical trial, just quite aren't ready yet. So next, let's transition to the opportunities for our newest investigators and our trainees. So the NIH has many different ways of coming into the NIH. We basically cover the career stage from a graduate all the way to independence. So let's start with the fellowships or the F awards. The Ruth L. Kirstein National Research Service Awards, or NRSAs, are pretty well known. F30, F31, F32, and more recently, F99, K00. These cover graduate through postgraduate training for PhDs or are dual applicant or MD applicants. Eligibility can begin before entering the laboratory of the final mentor, so do be thinking about this early. It does have a citizen or a national or permanent residency requirement, so be aware that this is quite open to everyone. The opportunities are in basic and clinical research, but a fellow cannot lead a clinical trial. They can be part of a mentor's clinical work, but they cannot lead the trial. So very high-level advice for our fellows: contact program staff early. I mentioned eligibility may actually begin before you get into your mentor's lab, and it may end much sooner than you expect. This is at least in part due to how long it takes for NIH award to go out the door. Contact us. The other thing is to think about where you are in your career. So many fellows have classwork. They are significant training requirements. And so don't go too big. Don't go too ambitious. And also, while we fully acknowledge this is a mentored award, don't overlap with your mentor's funded work. So don't take aim 2 of your mentor's R1. This is supposed to be your work with your mentor's advice and guidance. So moving on to our Mentored Career Development Awards, or K awards. These are a little bit less well known, partly because of how confusing they are. Not every IC participates in all of the FOAs, so contact program. Again, training has to be done here in the US as a citizenship or permanent residency requirement. The goal here isn't really training, it's preparing for independence. So again, opportunities are in basic and clinical research, and now, depending on the K application, clinical trials could be allowed. This is protected time, and it is truly meant to be intensive career development and research experience. For those of you who have a lot of other time requirements, it does require 75% health-related research effort. So just keep that in mind. I do think there are some exceptions to do contact program. Some more high-level advice, similar to the fellowships. Look at your career, look at your long-term goals. Make the reviewers confident that you are on track for independence. That at the end of this award, you will be well poised to start your own research project. But this is not an R1. Again, don't go too big. You are still in the mentored phase. You still are learning. So just be aware that this is a career development award. And it is a mentored award. The mentor's participation is also very important. They need to be able to provide significant details about the mentoring plan. Formal mentoring committees are still really recommended for Ks. And if you have outside advisors and collaborators, include them in your application. That's really impressive. Our next group is our Transition to Independence Awards. So the actual transition to independence, or the K99 or 00, is pretty well known. This is the big one. People know about this. It has no citizenship requirement, which is good, but it does have a really tight window. Those 4 years go by fast. So think about this one pretty early, and do be aware that there is the ability to request an extension. So the NIH is aware that life happens, training can get complicated. Look into it. It's worth asking. The other program is the Early Independence Award, or a DP5. This is through the NIH Office of the Director. These are really rare and very competitive. These are actually skipping the postdoc altogether. So this is really for that unique applicant who can leave their graduate career ready to own their own lab. Look into it. It's very competitive. So those of you who are leaving your training phases are probably thinking about applying for your own major research grant. So I'm going to take you through the definitions that are pretty important for those first R1s. So the new investigator and early stage investigator, what's the difference? So a new investigator is any PD or PI who hasn't gotten that big NIH research award. So you can have been on a T, had an F or a K or an L, which is loan repayments, a small research award like an R03, or anything that's not research related. So instrument, a conference, but if you've had an R1, you're not new anymore. Now the ESI, this is someone who is new and still within 10 years of getting their terminal degree or finishing their medical training. Everything now for the ESI status is done directly in ERA Commons. So this is where you put in your training completion dates and where you apply for any extension. So what are the advantages of being a new I or an ESI? So during review, new I and ESI R1s are actually reviewed together away from the more established R01 applicants. This is because reviewers are aware that a new investigator doesn't have years upon years of time and funding to get that preliminary data or that really solid publication. So this is to remind reviewers that this applicant may have a really good idea and a lot of potential, but may not necessarily really have that long-standing record. Now, the ESI is also really important because a lot of our SCs actually have a slightly more forgiving timeline for those at the ESI stage. We really want to support our newest investigators. So there were a couple more things for early stage investigators. Now, I put in here the traditional R1, which is open to everyone. But I do want to remind people that that is probably your best bet. It is the most used mechanism, the most funded mechanism, the one that your mentor and your collaborator are the most familiar with. It's not a bad place to go, especially if you're an ESI and you have that extended team. The two other opportunities that people may not have heard of. The Stephen Katz Early Stage Investigator R01, that's actually named after the late and well-respected director of my institute, NIAMS. So this one is pretty new. It's very different than the other one. This is actually no preliminary data allowed, which means that if you put preliminary data in, we're going to send it back and it won't even look at it. It has to be a change of research direction. So this can't be your postdoc work that you're now kind of expanding and turning into your own. This has to be really new. And it does have to be ESI applicants only, not even new applicants. And then there's also, as the Office of Director, similar to that DP5, it's a new innovator award. It's ESI only. This is no preliminary data required. So you can put preliminary data in. You don't have to if you don't have it. If you put it in, remember it can be reviewed. Put your best foot forward. The goal here is to fund the most creative and innovative early stage investigators. So these are those really high impact projects, and it's very competitive. So I wanted to close out by giving kind of a resource slide. So I mentioned many times that you can apply for extensions. These can be for family-related issues or, pandemic-related issues. So take a screenshot and just think about when you're thinking about your next career stage. There are ways the NIH is willing to help you and work with you. So contact your program director. So that can be me, Emily Carifi, NIAMS. If I'm not the right person, I'll try to help you find the right person. Email me. Dr. Amanda Boyce, also at NIAMS. She knows the training program front to back to front, upside down. She's amazing. Dr. Glen Nuckolls, who you heard from earlier today, he's at NINDS. This is important because NIMS and NINDS have slightly different eligibility criteria, different timelines, so you may need to talk to us both. I hope today was helpful, and thank you again.
Hello, my name is Natalie Street, and I'm a health scientist with CDC's Rare Disorders and Health Outcomes team within the Division of Birth Defects and Infant Disorders at the National Center on Birth Defects and Developmental Disabilities. I appreciate the opportunity to present to you today on the CDC-funded Muscular Dystrophy Surveillance, Tracking, and Research Network, or MD STARNET. During today's presentation, I will briefly cover the background and methodology for MD STARNET, describe data from the MD STARNET pilot on the sociodemographic and clinical profile of people with myotonic dystrophy, current data collection and myotonic dystrophy research activities, and future directions for MD STARNET. I'm first going to provide a brief background and history of MD STARNET. After the MD Care Act of 2001 was passed, MD STARNET began in 2002 with population-based surveillance for Duchenne and Becker muscular dystrophies. From 2002 to 2011, we identified and collected demographic and extensive clinical data on individuals with Duchenne and Becker who resided in up to 6 sites. Using data collected during this time period, we published key articles on prevalence, diagnostic delay and mean age of diagnosis, trends and use of corticosteroids, Duchenne-specific growth charts, and descriptions of healthcare service use and treatments. Additionally, MD STARNET data have been shared with policymakers such as the FDA and state Medicaid boards that have assisted in informing decisions on the designation of Duchenne as a pediatric condition and also drug coverage. So what is MD STARNET? It is a multi-site, population-based surveillance system for muscular dystrophies. Through active surveillance, we attempt to identify all people with muscular dystrophies who seek clinical care in specific geographic areas in the US, and we follow them over time. Sources used for identifying cases and for data collection include neuromuscular clinics, vital records, hospital discharge data, hospitals, and other outpatient clinics. Each site received IRB approval or exemption, and most sites have public health authority to conduct surveillance for muscular dystrophy. In 2011, after 10 years of experience conducting surveillance for Duchenne and Becker muscular dystrophies, we decided to conduct a pilot in which we expanded data collection to 7 other major types of muscular dystrophy, including myotonic dystrophy. The purpose of the pilot was to test whether the existing methodology and infrastructure of MD STARNET could be used to identify people with other types of muscular dystrophy. For the pilot, since our focus was on identifying people with muscular dystrophy, we pulled back on the amount of clinical data collected for each person and focused on demographic and key clinical variables, primarily collected from the most recent clinical visit. Our eligibility criteria for the pilot was that a case had to be encountered in the healthcare system between 2007 and 2011, be a resident of that site, and have a diagnosis in the medical record of one of the 9 eligible MD types. We published 2 papers describing the sociodemographic and clinical characteristics of people with muscular dystrophy residing in the 4 pilot sites. In the next few slides, I will present the results from those articles for individuals with myotonic dystrophy. Across 4 sites of 2,862 muscular dystrophy cases, 33% had myotonic dystrophy, which was the most frequent muscular dystrophy we identified. Mean age of those with myotonic dystrophy was almost 40 years. Consistent with the autosomal dominant inheritance pattern, half were male and half were female. 85% were white. 46% had a genetic diagnosis either for themselves or a family member. and 72% had a family history of myotonic dystrophy. Regarding most recent insurance status, from this chart, you can see that about half of those with myotonic dystrophy had public insurance, such as Medicare or Medicaid. About 1/3 had private health insurance only, and nearly 10% had both. For about 5%, insurance coverage was not documented in the medical record, and only about 2% indicated that they were uninsured. Employment was also collected from the medical record. Employment categories included those working for pay, disabled, unable to work, unemployed, and in the other category, people who were retired, homemakers, or those with unknown employments. As you can see from the table, the percent of those working for pay decreased with age, and the percentage of disabled or unable to work increased with age. For most recently reported ambulatory status, 13% of 2 to 9-year-olds and 5% of 10 to 17-year-olds were non-ambulatory. In adults, the percent of non-ambulatory individuals increased with age from 4% of 18 to 29-year-olds to 25% in those 75 years and older. The majority of people with myotonic dystrophy in the 4 sites had no clinical interventions reported. But the most common clinical intervention was respiratory, with 23% of individuals reporting the use of non-invasive positive pressure ventilation. Tracheostomy was reported in 7%. However, fewer than 1% reported using a cough assist. In terms of cardiac interventions, 10% reported having a pacemaker and 4% an implantable defibrillator. Only 1 person had a cardiac transplant. Regarding GI interventions, percutaneous endoscopic gastrostomy was present in 11% of individuals with myotonic dystrophy. Mean and median ages of death and causes of death were obtained from death records. The mean age of death for those who died between 2007 and 2011 was about 54 years old. Regarding causes of death, an individual may have more than one cause of death recorded. As you can see from the table, muscular dystrophy was most frequently reported as a cause of death, followed by respiratory, other, cardiac, and lower percentages who died from cancer or stroke. These data should be interpreted cautiously due to small numbers. Furthermore, causes of death and death records can be inaccurate and vague. We intend to follow up with further investigations into survival and cause of death with data we are currently collecting. At the end of the pilot, we concluded that the MD STARNET methods and infrastructure developed for data collection for Duchenne-Becker muscular dystrophy could be used for surveillance of other muscular dystrophies. However, more time was needed to identify people with myotonic dystrophy and other muscular dystrophies who sought healthcare at hospitals and other outpatient sources. We also acknowledge that we will only find those who come to medical attention and are less likely to identify those who are mildly affected or asymptomatic. Even so, surveillance enables us to answer important public health and clinical questions on a population level. After the pilot, MD STARNET objectives were modified to include the other muscular dystrophies. We increased the amount of clinical data collected for each person with one of the 9 major MD types, expanded the number of sites from 4 to 6, and we developed a research agenda to guide research and focus on important knowledge gaps. In 2019, we pulled the first clinical analytic data set on individuals with myotonic dystrophy in the 6 sites. And you can see the sites listed here on the map. The MD STARNET objective is to identify and track the health of individuals with eligible muscular dystrophies, to provide information on the prevalence of people who are clinically diagnosed and their survival, determine disease progression, healthcare service use, and describe disparities in access to care. We also want to compare the care that individuals with myotonic dystrophy receive to the care recommended in the recently published guidelines, the association of treatment on disease progression and survival, and the impact of having muscular dystrophy on the lives of affected individuals and their families. There is a robust process for reviewing and classifying cases. Each case undergoes review by a clinical review committee composed of clinicians who treat patients with muscular dystrophy and is assigned a case definition. Definite cases are those with clinical signs and symptoms of myotonic dystrophy and a DNA diagnosis in the case or a family member. Probable cases have clinical signs and symptoms and a family history without genetic confirmation. Possible cases have a diagnosis of myotonic dystrophy in the medical record. Asymptomatic cases have a genetic diagnosis but no clinical signs or symptoms. The Clinical Review Committee also further subtypes cases into myotonic type 1 and type 2 based on genetic and or clinical information available. Eligibility criteria for myotonic dystrophy was similar to the pilot, but with a couple key differences. In addition to being a resident of the site, a person had to have a health encounter between 2008 and 2016 and be diagnosed during or after 2008. While this decreased the number of people with myotonic dystrophy on whom we were collecting data, it improved the ability to get a more complete clinical history from medical records. The resulting 2019 dataset includes 486 individuals with myotonic dystrophy across 6 sites, with 343 classified as definite, 128 as probable, and 15 as asymptomatic. In this dataset, we expanded the amount of clinical data collected on eligible people with myotonic dystrophy. We continued to collect demographic variables such as name, address, date of birth, vital status, race, ethnicity, employment, schooling, and insurance history. We also collected information about diagnosis, including signs and symptoms, family history, and genetic testing. Other clinical information includes cardiac data such as ECG, echo, MRI, and Holter results, plus pulmonary and sleep testing data, and presence of certain neurobehavioral conditions. Also included are vitals such as height, weight, blood pressure, heart rate, pain score, and pain location, dates and reasons for hospitalizations, medications, procedures, mobility status, rehabilitation, and comorbid conditions. We gather medical provider type and medical visit dates for all healthcare visits. As you can see, the amount of data collected for each person was quite extensive. Research using this data is currently underway. One study is determining patterns of symptoms around the time of diagnosis and whether they differ by sex or repeat number. Another study is using MD STARNET and hospital discharge data to identify the cause and type of injury right before and after diagnosis of myotonic dystrophy. A third will describe cardiac manifestations, assessment, and interventions such as pacemakers and defibrillators. A fourth is looking at the frequency of opioid and non-opioid pain medication use in people with myotonic dystrophy. A fifth study is determining the frequency of cardiovascular and metabolic conditions such as hypertension, hypercholesterolemia, type 2 diabetes, and obesity in comparison with the general population. And another study is describing the respiratory manifestations, assessments, and interventions in people with myotonic dystrophy. In 2019, we expanded from 6 sites to 7 sites shown here. We are currently collecting data that will be used to determine clinically diagnosed prevalence and describe survival in the myotonic dystrophy population. To estimate prevalence, we expanded eligibility criteria to those diagnosed before 2008. In the near future, we plan to implement a survey within the MD STARNET sites among adults with various types of muscular dystrophy, including myotonic dystrophy. This web-based survey will assess the experience and management of pain and fatigue and experience of pregnancy and infertility. It will also ask about whether a participant developed COVID-19 and its severity, as well as the person's vaccination status. We will also be asking about annual flu vaccination status. In the future, we will also be collecting additional clinical data for individuals with myotonic dystrophy to evaluate how care received compares with the recommended care from guidelines. We will continue to analyze data and to provide results to clinical providers, advocates, and policymakers to help inform decisions. Lastly, we also want to encourage investigators to collaborate with CDC and MD STARNET investigators on publications using MD STARNET data. So many people have contributed to MD STARNET. I would like to thank investigators and staff at the MD STARNET sites and CDC for all the work they have done and continue to do, and all the individuals with myotonic dystrophy and other muscular dystrophies who have contributed their data to understand the impact and ultimately improve the lives of people living with muscular dystrophy. Please do not hesitate to contact me with questions or visit the CDC website if you are interested in learning more about MD STARNET. Thank you for your attention.